Okay, good afternoon. For those that do not know me, I'm Stu Haig, Practice Liaison Officer for NUH LMC. Today we've got two parts to this session where we're going to be joined by our chair, Dr. Shan Hussain, who's going to give a bit of an update in terms of local collective practice action. And then we'll go to part two where we're joined by various colleagues from Nottingham and Nottinghamshire ICB, which has been led by Stuart Newman, Vicky Fleming, and a few other colleagues. So without further ado, I'll just go over to Shan. Shan, are you there by any chance?
Yes, I'm here. Hello, Stu. Hi, everyone.
Hello, how are you?
I'm fine. Can you hear me okay?
We can do, yes, thank you. If you'd like to start.
Camera on as well. Okay, so thank you very much, everyone, for joining us. So you should have received an email from us, and also if you're part of the WhatsApp group, we've written a letter to the ICB, basically expressing our concerns about where things are at the moment and how the BMA is supporting practices to undertake local collective action. So we've thought about this long and hard, and we put a fairly lengthy letter together, which would really urge you all to share with your team, with the partners, have a discussion and determine which of the items you'd like to consider taking as a practice. We have communicated these intentions with the ICB. The response has not been particularly good, nor that we're expecting it to be. But I think what we need to look at is reminding ourselves that safe working is paramount, and the well-being of our GPs and our practice staff really comes first. And the purpose behind this action is to promote safe working, to reduce the growing workload that we are persistently being presented with, and to promote self-care. So obviously, it's early days. We have heard from a few practices, and it looks like the response so far, whilst minimal, has been positive. If you do have any questions about the content of the letter, then please do reach out to the liaison team. We'd be happy to discuss it further, and Michael and I will be doing a review with this with you in the meeting in 2 weeks' time. That's really all I had to say. If you have any questions, I'll be do my best to answer them for you.
Okay, Andrew, you got your hand up. Would you like to come in?
Yeah, please. Shan, I don't know if Michael fed back after last week's meeting. We discussed advice and guidance, and he was going to clarify what he meant. I think he came over not how he intended in terms of the letter. So maybe just have a. Oh, he's on. Okay, I'll leave it to Michael to feedback on that one if he hasn't already. That's all.
Thanks, Andrew. Yeah, if you don't mind coming in, Shan. Yeah, I mean, the wording to the practices was more what the spirit of it was, which was essentially that we don't want advice and guidance and this new DES, the £20 per request. We don't want that to become a feeling that it has to replace a valid referral. We don't want GPs to feel pressured into using advice and guidance where otherwise they were quite happy with a valid referral. So it certainly wasn't a boycott of advice and guidance. I think the letter we sent to the ICB probably looked more like that's what we were planning, but what we sent to the practices was expanding on that point. So we will be producing guidance on A&G, and I'm sure the ICB will want to talk about that as well. So we're going to do our own guidance on that. And again, like I say, it has its place. There is a clinical case for it. But what we would be resistant of is any pressure on practices to do advice and guidance as opposed to a good referral if that's what practices want to do. So that's the clarity, really. There's certainly no boycott or walking away from advice and guidance en masse. We're certainly not going to push for that. Does that help, Andrew?
In addition.
Yeah, it does, Michael. Can we also, could myself and you have a bit of a chat? We took your comments about capping on board. So we're trying to temper that to sort of balance up. We've got a fixed budget here, but we do want it to be used. We completely took your point on that. So we don't want to rush towards an unnecessary cap. But on the other hand, we want to protect all practices' ability to be able to utilise their fair share. So we want to sort of work out some sort of compromise arrangement where we make sure we don't put in an unnecessary cap, as I say. So if we could maybe have a chat about how we kind of term that, if you're around at all in the next week, that'd be great.
Yeah, let's do it, Andrew. Yeah, if you want to let me know when you're around outside of here, we'll do it as soon as we can.
Cheers.
Yeah, thanks.
Thank you very much. Any other questions from anybody at all about the local collective action letter? Great. So hopefully it's fairly self-explanatory. If you do think of anything, feel free to reach out to any of us. And in the meantime, I'll hand back to Stu. Thank you very much.
Excellent. Thank you very much, Shan. So hopefully people would have seen that over the last week or so in terms of the letter. If you haven't, please contact us at liaison@notslmc.co.uk and we can hopefully try and provide that information to you. Okay, we'll move on to the second part. So it's lovely to see colleagues from the ICB. Thank you, Stuart, Andrew, colleagues, for joining us today. Who would like to start?
So if I kick off, so I think we've got an update from the estates team. We're expecting an update around the clinical design authority. We're just chasing up the person that's meant to be talking to that, and then Meds Optimisation are joining us at 12:30. We've got a brief primary care IT update as well, and then obviously the usual update from us. So is it okay if we start with estates? Is that Gemma? Are you on?
Hi, Stuart. It's myself and Elizabeth, so
streamlined as ever. Hey, good afternoon, everyone. I'm Elizabeth Smith, Estates Manager for the ICB. Can you see that slide I've just shared? Or
No,
not?
there's nothing.
Not as yet.
Okay, bear with. Continuing with the streamlining.
It's a Monday, Elizabeth. Don't worry.
That's okay. I'm just hopeless at sharing anything, really. Right. Can we see that now? Hopefully.
We can, yeah, thank you.
Yes. Okay. Right. So there's a few primary care estates updates to give. I'll start with the PCN estates toolkits. So, as I'm sure most of you are aware, back in 2021, NHS England launched a national programme to support PCNs in developing their estate strategies, and we've worked with all PCNs since that time to develop these. That followed some earlier work, which included the primary care data gathering exercise, which was undertaken in order to establish a national baseline of primary care premises data, which was fed into the SHAPE database for anybody who's heard of that. It's a database used by public sector. We also undertook 6 facet surveys on all owner-occupied and private lease premises to establish, again, base estates data, including physical condition, functional suitability of the premises, quality, fire and health and safety compliance, and environmental management. NHSE appointed community health partnerships to lead on the PCN toolkit strategy work and to work with ourselves and the PCNs towards 2 main objectives, which were to identify estates priorities for each PCN and to support wider ICS capital planning. The programme started in earnest in Nottinghamshire at the beginning of 2023 after a difficult and challenging lead-in period for various reasons. I think nationally there are a few wobbles, so hopefully we managed to surpass those. Each PCN received an individual report tailored to their PCN by the end of 2023. For a number of reasons, the ICB final aggregated report was not finished before the national programme ended, and the prioritised pipeline of schemes was not completed. So to address this matter, we held subsequent workshops in all 4 places in order to review, validate and update the PCN priorities highlighted in the strategy work. The last session took place in Bassett Law in March 2025, and feedback received from all has been positive, and follow-up sessions are going to be planned in as well. So we're keeping everything up to date with all PCNs. So obviously we appreciate that estate's continually changing. Whilst the aggregated ICB report was incomplete, it did serve to confirm the key known priority areas and also highlight a number of operational issues, such as access to bookable spaces for practices in NHSPS and lift buildings, which were managed to sort. It also gave practices and PCNs the opportunity to progress some of their low-level suggestions for estates. The intention moving forward is to add a concluding section to the report, which demonstrates what has been achieved in the last 18 months and also links the remaining priorities into the ICS infrastructure strategy. So that leads me on nicely to the ICS infrastructure strategy. It runs from 2024 to 2039. The strategy has been developed to reflect and respond to the vision and strategic priorities set out in the Integrated Care Strategy and NHS Joint Forward Plan. It's to be signed off by the ICB board in May 2025. And for primary care, the investment priorities have been identified as basically three main areas: housing development driven, priority geographical areas. So there are three main housing developments in the planning pipeline, all requiring primary care capacity, and work is ongoing with developers to secure primary care facilities for the Fareham Pastures, Chetwynd Barracks and Tollerton and Bassingfield developments. The second category there is development required for population growth. So creation of capacity through new builds, which will address estate infrastructure issues and population growth in the following areas: Hucknall, Eastwood and Giltbrook, Eastleek, Newark and Beeston. And finally, requirements which are condition driven. So buildings that due to the current condition require priority, including Radcliffe-on-Trent, Strelly and Aspley area, Burton Joyce and Edwinstowe and Ollerton areas. And our team are working with developers and partners to meet demand in all of these areas, along with many other schemes, as I'm sure you're aware. Okay, so next, moving on to the premises cost directions updates. Again, as I'm sure you're all aware, there was an update released in May 2024. One of those updates removed the requirement for ICBs to restrict the NHS contribution to between 33% and 66%, and made provision for all schemes to be fully funded at 100%. Initial NHS comms advised that we stick with 66% unless there were exceptional circumstances. However, more recent funding issued by NHSE, which is the Utilisation and Modernisation Fund, has been issued at 100%. So, excuse me. So in response to that, our usual business as usual Commissioner Capital was obviously issued previously on a 66%, 34% basis. However, following the introduction of the UMF funding, Utilisation and Modernisation funding, and in order to avoid creating a two-tier funding system, it has now been agreed internally that we can bring the BAU in line with the UMF funding to be provided at 100% across the board. This approach is felt to be more equitable across all types of practice property, whether owner-occupied, leased or NHSPS lift buildings, and should ensure that the ICB is making best use of its capital allocations to support practice premises improvements or developments. The change is an operational matter and was noted by the Finance and Performance Committee on the 26th of March 2025. It does not affect the scheme of reservation and delegation. And moving on to capital funding for this next financial year, we've received two capital allocations, which are the business as usual BAU grant and the Utilisation and Modernisation grant. The UMF, as we call it, funding was announced during the 2024 government spending review, and it provides additional capital funding intended to be invested in minor estate schemes which increase the utilisation of existing primary care sites. The intention is to improve patient health outcomes, create additional patient-facing capacity, and increase the number of appointments delivered in primary care. The ICB have submitted 22 prioritised schemes, which have all been now supported in principle for progression by NHS England, and we're currently working through project initiation documents, PIDs, and due diligence documentation with the practices involved. All of those schemes must be completed by the end of December this year. Any schemes that were submitted by practices that either weren't ready to go due to the very fast turnaround imposed on us, or weren't eligible for the Utilisation and Modernisation funding, are being considered for the next financial year, 25-26 BAU capital or the 26-27 UMF capital. So hopefully we'll be building a strong pipeline for future investment. And then finally moving on to the primary care transformation and integrated neighbourhood teams. Following the publication of the NHS neighbourhood guidelines and the focus of neighbourhood health in the forthcoming 10-year plan, the need to transform primary and community care to support care close to home will need flexible, fit-for-purpose estate. The work done through the PCN Estates toolkits to categorise the buildings into core, tail and flex, together with information in the ICS infrastructure strategy, provide a good foundation on where neighbourhood hubs may be best located. The wider partner estate, the One Public Estate programme, OPE programme, supports locally led partnerships of public sector bodies to collaborate around their public service delivery strategies and estates needs. Early involvement of emerging INT delivery plans is key to identifying the most appropriate estate for them. So in conclusion, good progress has been made in developing strategic plans and unlocking capital for primary care estate. However, there's still work to do in terms of consolidating reports and progressing the next pipeline of schemes. Thank you very much for your time, everybody.
Hi, Elizabeth. Thank you very much for that.
Sorry, that was a lot.
It was a lot, yeah, really useful. I think somebody just put a comment in the chat. If it's possible, just to go back to the strategy parts, would that be possible, please? I think we're keen.
Toolkit strategies.
So it was no, not the PCN. It was the second one down from that.
Okay.
On that
screen's just
list.
Gone wonky on me. Bear with me a moment.
That's all right.
Lost my paperwork. Hold on, the strategies. Oh, come on down. Okay, so was this the housing development,
Yes.
population growth and condition driven?
Yeah. I'll just bring Louise in. Was that the part you
Yeah.
wanted to hear again, Louise?
Yes, sorry, it's me. Yes, it was just very quick, and some of those areas affect our kind of patient catchment. And then also, if practices didn't apply last time round because of capacity or whatever it was, but other practices have been slid over into the subsequent year, is there still going to be an opportunity for practices to apply for those years as well?
For the following financial year, 26, 27,
26,
there'll always be
27.
opportunities on an annual basis to apply for the business as usual capital, and hopefully moving forward we'll be able to retain the utilisation and modernisation capital. The hope for that one is to retain it for the next 4 years. It very much depends on nationally. It depends on the first year spend and how well it's spent nationally. But yes, we tend to go out at the beginning of the year, probably January, February time, to practices. But if you do have schemes, we always encourage practices to make contact with us at any time in the year, because there are some schemes occasionally that are supported but don't come to fruition for some reason, whether it's contractor issues or the practice can't complete for some reasons.
Yeah.
So it's always good to have kind of other, sometimes smaller schemes in the pipeline that we could bring forward. And if there are any large schemes, then obviously we can discuss with the practice and try and plan those in, so we're aware of them. The concept for the next financial year with the utilisation and modernisation funding is to hopefully expand that to be able to cover extensions, but we're still waiting updates on that. Obviously, as I'm sure you're all aware, the ICB hasn't got a great deal of revenue to support those at the moment, which is why we're focusing this year on just conversion of internal existing areas.
Yeah.
But no, if anybody's got any schemes or any questions, just get in contact with the estates team and we'll pick them up with you.
Okay, could you run through those areas again then quickly? Thank you.
Yeah. So for the ICS infrastructure strategy, there are 3 main areas. So the first one is basically need caused by a great deal of housing development. So they include fair and pastures, Chetwynd Barracks, and Tollerton and Bassingfield. There are other schemes in the pipeline as well for other areas, but I think they're the main three that have been identified for this next financial year. The other main area of growth is due to population growth. So where new builds are required to address estate infrastructure issues and severe population growth in the following areas, which include Hucknall, Eastwood and Giltbrook, Eastleek, Newark and Beeston. And then finally, areas identified due to the condition of the existing primary care estate, which include Radcliffe-on-Trent, Strelly and Aspley, Burton Joyce and Edwinstowe and Ollerton. That doesn't obviously mean that all other areas are off the table, but they're just the focuses that have been included in the estate strategy.
Great stuff. Excellent. Thank you very much, Elizabeth. There's a question in the chat from Dr. Balakrishnan. Can practice apply for utilisation funding this year, can apply next year for extension scheme?
We will take applications. As I said, if you've got any schemes, contact us at any point and then we can factor them in and work with the practice to see what's feasible. We are hoping on a national basis that we will be able to support extensions where required in the next financial year. But as I said, that very much depends on ICB revenue being available to fund the additional rent that would be required on such schemes.
Okay. You mentioned the strategy will be published in the next couple of weeks, or a decision made by colleagues from the ICB in May.
Yeah, I think it's going to board the May 2025 board.
Okay, so that information may be published very soon then, so keep an eye on. Excellent. Thank you very much, Elizabeth. Any questions for Elizabeth and the estates team? Dr. Abbott, would you like to come in?
You mentioned I was very much involved in many hours of preparing and discussing with the management consultants who came last year to about the PCN's estates for our PCN. But then I've not heard anything back from it since, and I wasn't aware of these workshops that you mentioned. Did you say that there were reports or that you'd come to some, you'd produce reports per PCN about the conclusions of all that?
All of the PCNs should have received their own strategy, a copy of their own strategy at the end of the actual work that took place. And there were some follow-up sessions that took place across each place area. I'm just thinking Nikki's going to come in now and give us an update about the one that took place in the city. Do you want to comment, Nikki?
Thank you.
Hi, Nikki, are you there? Just joined.
All right.
Nikki
Hello,
Glencroft.
me.
Hi.
Hello, sorry.
That's all right. Thanks for joining.
Sorry, Nikki, I don't know if you heard. We've received a
sorry.
question from Dr. Abbott about the city area in terms of the Thriving City event that took place. I think I've just found here it took place in September 2023, that one did.
It did. Sorry, what was the question? I literally joined and just heard my name.
Sorry, Nikki, I didn't realise you just joined. I thought you were flagging up to speak at that point. Dr. Abbott just asked what the outcome of that event was, because she'd not heard anything since. So I just explained that the PCN toolkits, all of the PCN toolkit strategies will have been shared with the PCNs, and then we've done a follow-up event with each area since.
That's right. Yeah, I understand. I'd have to dig out some bits from the city one. I was only really involved in the Mid-Knots one.
Okay. So
Well,
would there be any... Sorry. Dr. Abbott.
Yeah. Are there any published reports on all those different on the different places from those, the outcomes of that?
From those workshops that are carried out?
Yes.
Yeah, so from what I understand, and Liz, please correct me if I'm wrong. So everything that was taken away from those events, there was lists of sort of you said we did basically, and those were fed back to the different PCNs. Is that correct, Liz? Have I got that right?
As far as I'm aware, yes. Sorry, I wasn't involved in the city one either, and we've had some staff changes since then. But yes, I believe they were sent back. And they were further updated for the city. I'm just having a look on the file in October 2024 with the PCN.
I think you're looking at the same as the information I've got.
So would it be worth recirculating them, do you think?
Yeah, please.
Yeah, can certainly do that. No problem at all.
Thank you, Liz.
Thank you.
Okay. Thank you very much, Liz. We'll move on to the next colleague in the ICB, if we may.
Yeah, so I think if I go next, we're just waiting for Meds Optimisation to join. I'm afraid it looks like the update from the CDA will have to be deferred because the person that was due to present is actually on leave today, which I apologise for. So I'll just share my screen.
Thank you, Stuart.
Is that there? Yeah.
Yep, we can see it. Thank you.
Cool. Okay, so there's just a brief summary of the national contract, which I think people have all seen. I think the main thing we're still waiting for some more information about the PCN DES capacity and access payments and how that will operate. And there's another slide coming up around advice and guidance in a bit more detail. I think the other main national update since the last time we came is around the impact of the changes to NHS England and the ICB. So as people have probably seen, NHS England and the Department of Health and Social Care are going to be merged. So NHS England will be reduced in size, but what probably wasn't covered in as much detail in the press was that ICBs will also be significantly reduced going forward. So we've been asked to reduce our management costs by a half by the end of the third quarter this year. So I think where we are with that is that by the end of this month, we should have a clearer idea of what the role and function of ICBs going forward is going to look like. And then during May and then into the summer, we'll then be going through the process of looking at how we transition from what we've got now into that future model. It may mean changes to the configuration of ICBs locally. So there may be some ICBs. Well, there'll almost inevitably be closer working between ICBs, and there may be some mergers as well. And I think it's worth mentioning because it probably will have a sort of reduction of that size will inevitably impact on how the ICBs going forward relate to general practice. In terms of advice and guidance, do you want to speak to this one, Andrew?
Yeah, happy to. Yeah. I think you've mentioned practices should be getting the formal offer to sign up to the enhanced service. If it's not gone out, it will go out. I think we set an internal deadline ourselves by 29th of April, so tomorrow. They've got till the 27th of May to then sign up via CQRS. I believe that's probably also gone live today. So I'd advise, it's kind of a no-lose gamble. I don't see why practices wouldn't sign up to the enhanced service. There's no penalties if you then don't actually make any advice and guidance requests and don't claim the funding. You kind of might as well leave yourself open to that. We're re-establishing our interface meeting. We've got a referrals optimization group. So I think the key thing to this is actually the conversations between primary care and secondary care to make sure this is a really useful process for everybody to try and get some sort of quality and also timeliness of responses, so this doesn't get in the way. With another survey, I'm afraid we are planning to do a bit of a survey about where people think we should be focusing in terms of our conversations with the acute trust, what they'd suggest, what people see as the pitfalls of the enhanced service of advice and guidance generally, and also how we've got a referral support service that some of you will be familiar with, whether or not we can redesign some of the work that they do to support advice and guidance, or whether that will just get in the way. So we would be really interested in people's views about that, whether there's anything that they can help sort of get over a bit of the admin hump on this, I suppose. And the final thing I've already mentioned to to Michael is we're kind of lathering about. We've got the ability to cap, and we've also got the ability to change that cap through the year. So we want to balance. This is a fixed. We've received the budget, I should say. We have received an indication of what our budget is for this from NHS England. It looks about 80,000 referrals worth of budget. So we want to make sure that everybody has fair access, but we don't waste that capacity. So we've got a bit of flexibility on that, but I'll have a chat with Michael about how we do that to both protect practices in terms of getting their fair share, but also make sure that we don't waste the opportunity here. That's about it at the moment.
Thanks, Andrew. And then this final updates in terms of local update. I've been talking at this meeting regularly about the local enhanced services contract offer. We presented that to the Strategic Planning and Integration Committee, the revised offer in April, and it's probably fair to say that the committee was supportive of the need to invest more in the local enhanced services offer, but the challenge back was that we needed to find the money internally to support that investment. So we're currently working to do that, and as soon as we can, we will come out with a revised offer. I think, as I said last time, if we can secure that additional investment, the intention is that would be backdated to the 1st of April. And I can only apologise that this is taking longer than I hoped, really. Just final bit there, just highlighting on the slide, really, the ICB's transformation priorities for the upcoming year to try and ensure that we balance our financial position. And just to highlight some of the key areas there, so there's a real focus around frailty, and how we better support people to remain independent and living in the community. Focus again on urgent and emergency care pathways, because you'll be aware there's still significant challenges in those pathways with long delays and excessive patient waits for care. Again, focus on planned care, of which advice and guidance is one element, and how we make best use of our planned care capacity, but also how we get more activity through and reduce waiting lists within a financially constrained environment. And then I think the other big one that will probably have an impact around the primary care is the community transformation program, and how we change and reconfigure our community services to develop what's known in the trade at the moment as integrated neighbourhood teams, so a sort of population focused team, potentially with staff coming out from secondary care, and then in the community services integrating more closely with primary care services and the other the pharmacists, optometrists and dentists as well. So I'll probably come back and talk about that in a bit more detail at a future meeting, or get colleagues to come and present potentially on specific ones when those plans are more fully worked up. So if I stop sharing there, if there's any questions, myself and Andrew are happy to take them, or if not, hopefully we'll have some colleagues from Meds Optimisation will have joined the call to talk to you.
Okay, they have joined. I saw Mindy earlier.
Brilliant.
Yes, we're here. We're here. Ready when you are.
Do you want to go for it then, Mindy? Yeah.
Oh, okay. Thank you. Firstly, as always, thank you very much for accommodating us. Lovely to see you all. I can see that we're probably needing to run through our items as quickly as possible in terms of the timing for your meeting. So I've just got a couple of introductory slides, and then I'm going to hand over to a couple of my colleagues to run through their items. So what I'm just planning to do in the next sort of 15 minutes or so is, apart from get the slides in the right place, is just to say that as a team, just picking up from Stuart's items there in terms of system transformation, we are looking specifically around wound care, medicines waste, and extending the continence prescription service and reviewing that for Mid-Knots and Bassett Law. Obviously, the team is working very closely with our community pharmacy leads to establish, develop and progress with the community pharmacy clinical services. And then something that I'd like to come back to you again in future is that we have a system polypharmacy program. It's in the very early stages, and we'll be really keen to bring that to you to discuss. Also, in a few minutes, I'll hand you over to Matt Lawson in our team, dietitian in our team, senior dietitian, to give you a dietetics update, and Cheryl for some progress that we've made after many years of hard labour, following on from some of the issues we ran into during COVID, actually, but a launch of a new process. So would welcome an opportunity for Cheryl to explain that. A few medicines optimization opportunities, and then really just to plug the PLT topics for April. We are going to do an overview of the practice prescriber visit program from last year and the new year. So any suggestions on how we could improve, tailor that, make it more useful for you. Also, there'll be items around tirzepatide prescribing in weight management as well as in diabetes. And of course, our usual NOTS area prescribing committee update, which will cover the topics just shown there. In terms of some of the focus areas that the team are working on, here's just a few examples here. And this is one of the slides that's lifted from the PLT session. So it's just to give you a taster that if you want more information, then the PLT sessions are the place to go. In terms of cost-effective prescribing, many of you will be familiar with certain elements in here, but I just wanted to emphasize the fact that we have an ICB-funded MMF scheme, which, all the training is provided by MedsOp leads. So please do sign up for that, and also the APC resources to help with that as well. But in particular, I wanted to focus on 2 ICB-funded schemes at the moment. And one of them in particular, which is the DOAC switch scheme, has a time limit on it at the moment of the 31st of May. Now, I will share these slides with Emma so that you can follow the links, etc., if you haven't signed up to it already. But please do. We've got, I think, over 44 practices that have already signed up and are delivering this. And so we can put you in touch with colleagues if you wanted more information about how the experience has been for them. And equally, the Medicines Management Facilitator scheme is also open. We'd strongly encourage practices, to join. Again, happy to put you in touch with colleagues of yours who are already part of the scheme. And that is an element that is also paid for at the moment. And here are the links to get further information. And then finally, just to plug the enormous contribution that our community pharmacy colleagues are continuing to make. This is just an infographic of the service provision from up to December 2024. We are getting fresh data. In fact, it'll probably be out this week. So I'm sorry that this is the old slide. We can share that with you. But I think the one thing I did want to point out to you is that within Nottingham, we have 4 independent prescribing pathfinder sites. Those 4 sites together, considering that actually 2 of them are only just come online, have done over 512 consultations to the end of December, and are playing a really significant role in their neighbourhoods with those services. But also, if you look at the number of consultations, which are increasing all the time, it's really good to see the progress that's making and the potential for more. So with that, I'll just stop sharing and hand over to Matt. I think it is, isn't it, first?
Yes. So good afternoon, everyone. Great to see you all. Matt is our senior medicines optimization dietitian, works tirelessly behind the scenes on all of our guidance, receives queries from you all, and helps with anything relating to prescribing and dietetics in general as well. So Matt's just going to have a quick run through some of the work he's been doing recently, just to highlight a couple of points that are very pertinent to yourselves. So I'll pass over to Matt. Hello, Matt.
Good afternoon, everybody. Thanks for having me on. Can everybody see that?
Yeah.
Perfect. I'll be as quick as possibly can. So yes, my name's Matt, with the dietitian with the medicines optimization team, and we really appreciate everybody's work over the last few years, because it's been a big improvement in terms of oral nutritional supplements, which has been a key area for us to focus on. And we've seen that in the numbers and everything. So we appreciate everybody's kind of time and work with this. So we're trying to prevent malnutrition by screening people as early as possible, make sure we're promoting a food first approach. And just to remind you that, you've got the dietitians there in Notts Healthcare and in City Care that you can refer patients to. So if they've got a must score of 2, 3 or 4, you can refer them and those referrals will be accepted so these people can be seen by a dietitian. The APC guidance is there for you as well to follow, but fundamentally it's this move towards powdered AIM shake as the first line product that we want to just emphasize. And over the last few years that the switch to that has made a huge difference for us. So we really appreciate that. And we're now on around 60% of people on powdered AIM shake. So a big change from previous. Overall, in our area, we're doing pretty well across the country. One of the best areas in the country for not prescribing products that haven't been approved by the Area Committee on Borderline Substances, so that's superb. But there's still a little bit more, that we could do. So can we increase that percentage of powdered ONS a little bit further? So AIM shake, for example, against something like 40-sip. And if we come across a patient, we're looking for things. How long have they been on ONS? Have we got a weight? Have we got a must score? And if it's someone on something like a 40-sip compact protein, one of these ready to serve sort of products, really specialist products that are quite expensive, it really should be on the recommendation of one of my colleagues or of a dietitian. And if that's not there, then we'd be looking at the appropriateness of that. One of the major changes I just wanted to come on today, the reason for me speaking today, is that I know that it's been a bit of a bugbear that this patient's leaving NUH in particular on 40-sip and because of their contractual arrangements with Nutricia at the moment, which is something we are trying to tackle longer term. But then there's kind of nothing on it, and it's difficult for GPs to then make that switch to AIMS and wondering if it's appropriate. But we've now had it agreed with NUH that it will pull into the TTO letter for every patient that's discharged on 40-sip bottle now, for example, and this will apply for all of Nutritious products. It will now say that post-discharge, GP can prescribe as per the local primary care guidelines. So hopefully that adds to the confidence to make that switch, because AIMS shake does exactly the same job. And unless there's a clear rationale from one of my colleagues, one of the dietitians, to specifically say why this patient needs 40-sip for whatever particular reason, then in primary care we should be using AIMS shake, and it can just help make a difference for us on that. So thanks for listening. If anybody's got any questions, I can take them, or if Cheryl wants to add any more.
I just wanted to say it's a massive step forward in terms of getting some message on TTOs. So I think the very quick summary you've given there, it sort of underestimates the amount of time and effort it took to get that agreement. So we'll be monitoring it closely.
Can I just jump in also? I've just seen a query from Andrew. Yes, that's our next step, to talk to Sherwood Forest Hospitals Trust about whether we can do something similar as well. So that's Matt has joined our transformation program, so that'll be one of the transformation plans we've got going forward under our medicines optimization program to get that sorted. So that's the next steps.
And
yeah,
Doncaster and Bassetlaw hospitals as well, if possible, please.
Yeah, we'll start ticking them off as we start to move around. Thank you very much.
By next week. No pressure, Matt.
No problem. Leave it with me.
Excellent. Dr. Butt, you got your hand up.
Yeah, I'm going to put a slight spanner in the works, Matt. Thank you for all the effort and hard work. And as Mindy said, massive step forward. But I would say, generally, an overall scheme of things, it's rotten. They prescribe something in hospital and then they expect us to prescribe something different in primary care. And the patients are vulnerable, they're malnourished, and their relatives. And quite often, they when you try and switch something, there's always this negative feeling from relatives saying, why are you switching something? The proper doctors in the hospitals put them on these other 40-sips, and why are you changing it? And it's kind of sends a wrong narrative to the community. So lots more work to do.
Go on, Matt, did you want to come back on that?
Yeah, no, just to say, completely agree with everything that you've just said. Everything you've said, spot on. And this is something that we're aware of. I'm part of a national group of dietitians that are trying to challenge this. And there's some ongoing work nationally to try and change this, to try and break up these contracts where, because the NUH dietitians can't do anything about this at the moment, unfortunately. It's due to a contractual arrangement that Nutricia have for their products to be used in the hospital, and then, like as we say, patients then get discharged on it. And they're essentially being provided for free to the hospital, and then we get charged, £2 a bottle or whatever in primary care. So it's unethical, it's not right. But these practices have been going on for many years. But we are desperate to change it, and there is some work afoot, finally, hopefully, to address this. It is a national issue, but I agree with everything you've said.
Yeah, and I think just Callie, just to come in there as well, in terms of linking this to some of the system transformation programs, means that we can work collectively on direct patient information and have a consistent message out from the trust so that it supports some of the changes that we may need to make in primary care. So that's all work in progress, but absolutely, take your point about the difficulties if a precedent seems to be set by secondary care.
Okay. Thank you, everyone. I appreciate time's pressing. So I'm just going to talk a little bit now about direction to administer. So my colleague Emma's joined the call with us, and hopefully she can share the slides because we're on different laptops sitting in one room here. This has been an ongoing issue for many years, as you're all aware, and we have been working behind the scenes for a very long time to get to the place that we will tell you we have reached to launch our new system on the 9th of June. So I can ask Emma to share the slides. I believe she's there.
Sorry to interrupt. So the slides aren't being shared at the moment, but there's a question in the chat in terms for Matt. So before we move on, can I just quickly ask a question to Matt, if I may, for Dr. Reid? So the question is, has there been a risk assessment on an automatic message? And if missed by the dietitian, then could mean GP changes and they actually require the specialist product? You still there, Matt?
Yes, still. I'm just reading it in the chat myself, actually, as well. I mean, it's all been agreed with my colleagues, the specialist dietitians at NUH. So this is something that we've worked up together. But I mean, I can certainly go back and make sure that it's bolts and braces and everything's totally correct there. But it's a very good point. I don't know if you've got any thoughts, Cheryl, but essentially, the dietitians, if there's a particular need where a patient needs a specialist product, it's part of their job as a healthcare professional to make that clear and explain the rationale as to why. And then that should, we wouldn't challenge that. We're talking about the general. Some of these patients haven't even seen a dietitian that get discharged on Fortisip. That's the reality. You got anything else on that one, Cheryl? Or
no, sorry. Yeah, I mean, Matt's done a lot of work behind the scenes, as he says, talking. Getting all of the dietitians talking together and looking at the processes within the hospital. So if it is a supplement which is so many calories per meal and they've been started on that, and there isn't, as he says, a dietitian who's made an intervention on the ward or with that patient, then they've sort of agreed that yes, it's okay to change to the powder product, which is an equivalent to Fortisip. So
okay. Dr. Reid, you got your hand up. Would you like to come in?
Yeah, I was just going to say, people are really busy in the hospital and just getting busier and busier, and it's there's a risk of omission, isn't there, here, when something is auto message to the GP. So I suppose if the one time the dietitian is seeing the patient and they think, yeah, it would be useful for this person to be on this for 3 months after discharge, then they should be making sure that gets prompted into the discharge summary. Otherwise, really, ultimately, we're storing up 1 month later. Oh, sorry, I've just hit my. Can you hear me?
Yes.
Yeah, 1 month later, where the patient's becoming increasingly malnourished or hasn't got the protein for their wound healing, and it will be the GP that ends up getting it in the neck for missing something. So. You can justify it within a week or two of the discharge, saying, yeah, it's the hospital's fault, but after that, it becomes the GP's problem.
Yeah,
and the district nurse and everyone else's.
Yeah, thank you for those points. We absolutely understand where your point of view on that. And again, this is something that's only recently changed, but we will have to keep a very close eye to make sure that it's operating in the way we have planned, because sometimes, as you say, there are things which slip by. But we'll take that away, and I'm sure Matt will have more conversations with his colleagues in secondary care on that. Okay.
Yes, thank you.
Thank you. So I've got the slides now. It's all right. And I will just quickly talk to you a little bit about where we're going with the direction to minister. Now, you're all aware, from many years ago, before we joined to be One ICS, there are a number of different systems in place to direct community nurses to administer medicines. So around when we did this work, it was when COVID around, because suddenly we didn't have people in GP practices, everybody was having to work remotely and so forth. But moving on from there, we realised that the issues were still there and we needed to form something much more robust. So we carried on the small working group we had in COVID. More people joined us. Since then, we've had lots of very helpful input and support from yourself, members of the audience today, yourselves, and many people across the ICS, in our informatics teams, our specialist palliative care nurses, consultants in palliative care. We've had everybody coming along to help us try and get to the place that we've reached now. And we've piloted our system in 3 BBPs. We've had GP input and feedback from nurses. And our next steps are to communicate what we're going to do, and that will be starting within the next couple of days. And we are planning to launch this system on the 9th of June. Now, just to bear in mind, this isn't a training session. We have got a training session all lined up, and there'll be lots of opportunities for people to access that. And thank you to everybody in the audience who've offered their support to help promote this at PCN meetings, practice meetings. We've got lots of people willing to help us, and thank you for that. So what it is, we've come together and we've standardised all of the forms for direction to administer across Nottingham, Nottinghamshire. You're probably aware we had ASS ones, DNS ones, and 2 or 3 other types, and there are all sort of different versions of them all over the place, and everybody was doing something different. And we decided we had to do one form that everybody agreed to, have one set of guidance and one set of governance, so that everybody was working along the same paths, because in the ICS people move around from different organisations and we needed it to be the same. So we now have 4 forms: a DA vitamin B12, a DA-AM for anticipatory medicines, and a DA-SD for syringe drivers, replacing all the ones that are in process at the moment. They will be digital for primary care, so they'll be saved on the electronic record, and we will pull the signature from the smart card, which means they don't have to have a wet signature. We have also finalised and formed up all of the forms coming out of the hospitals, so the TTO acts as a direction to administer, and the nurses shouldn't be asking GPs to write them. We've also put in place an outpatient form, so that people coming out of clinic in NUH are also issued with their DA coming out of clinic. And we have put in a separate process for EMIS practices, because there is an issue for EMIS and the community nurses being able to access the records in that way. So we appreciate we haven't quite got something in place for shared advice and outpatients, but we're working on it. There are lots of different threads in this. We're trying to get to a place where we can launch, and then we will still be working. We won't sort of run away and leave it as it is. So this is just an example of our direction to administer DA form. And then the next one down is our vitamin B12, which has been pre-populated to make it quicker and easier. We've also got our anticipatory medicines form, and we've worked really, really closely with a lot of our specialist consultants to make sure we get all of the details right on here, specialist pharmacists as well. And we've got that form also gives guidance in prescribing and guidance for nurses to know how to use dose ranges, because we've also agreed that across the patch. Previously, dose ranges weren't allowed for administration in Notts Healthcare Trust. They now are, which aligns with City Care. And we have also got our syringe driver forms, which we have worked really hard to make sure they're extremely clear, so that everybody knows what they're doing and which bits to fill in. So this long piece of work has brought us to this place. The feedback from the pilots is it is quicker, less chance of things being lost, it tightens up the governance, it makes things safer. And we're hoping that it ticks boxes for the majority of participants. As I said, I appreciate, there are a couple of things that we're still trying to solve, and some of the IT has got to catch up with us in the future to make this happen. But we will be coming out to you and launching this and letting you know how you can get a hold of us and how we can come to you and show you what's going to happen. We have got a training package that we will upload as well, and we will come out and visit people. I'm teaching all of the members of the Medicines Optimisation team how it works as well, so they will also know the answers. It won't just be the few of us in this little working group who've been beavering away at this for a very long time to get there. So that's where we are, and it's just a little bit of a pre-warning that this is coming, and hopefully it will tick lots of boxes and solve a lot of problems. So
excellent, thank you very much. There's a question from Dr. Calibut. Can I have Word forms of these DA forms, so we'll ensure they're on Arden templates? Thank you very much. And he's put his email chat in there.
Yeah, we've been talking to Callie before on this.
Okay.
So yes, yeah, we will come back to you on that one. Thank you.
Excellent. But a lot of brilliant work, and Dr. Balakrishnan said the same thing, and we've got some claps as well. So thank you for your hard work on trying to make things a bit better for primary care colleagues. So much appreciated.
It's just a sort of an observation also about how long it's actually taken us to even get to this position, because it was really in COVID, and actually, where there's a solution, we need to be getting to it a lot faster than we have been in the past. But really, thank you to everyone who's helped us get to this point.
Yeah, we're just hoping that this will make patient care, as I say, safer, quicker, and will save a bit of the environment for people not driving around looking for paper forms. So.
Yeah, perfect. Yeah, obviously we want to try and remove some of the bureaucracy, and it's only taken half a decade, maybe, to put it in those terms.
Yeah. The problem is when you start off, you don't realise how many little avenues there are to solve before you can come back to the main point.
I can imagine.
Thank you. So that's the kind of end of our update. You obviously welcome to reach out to us if you have any queries or anything you wish to follow up with. But otherwise, we welcome the opportunity to come back and keep you updated as we go forward. Thank you.
Thank you very much.
Okay, Stuart.
Yeah, so I think that's it from us, Stu. Yeah, thank you.
Okay, are there any questions for the team before they leave from our colleagues in the room?
Just one quick question. Did we say these forms are expected to go live in June? Ish.
Yes, so our launch date is the 9th of June, but we will have a little bit of a period of time when the other ones will still be valid. We won't say that's the end of the others, because we've got so many stakeholders across so many organisations. Somebody will pick up an old form or try and use it. So it won't be the nurses will come back on the 10th of June and say, oh no, we're not doing that anymore. We will have a period of time for sort of a handover. Yeah.
Excellent. Thank you very much.
Thank you.
Thank you.
A big thank you for coming today. Really do appreciate all your time from colleagues of the ICB. And we'll see you very soon for the remainder. So next week is a bank holiday Monday, so please don't come along and sit here because I won't be here. But the following week we'll be joined by Paul Miller and Monique Peak from the primary care IT team, and hopefully we'll see things. Hi Vicky, you've got your hand up, sorry. So you're on mute.
Hi, sorry. My name is Vicky Fleming. I'm one of the microbiologists at Queen's Medical Centre. I was going to be talking today very briefly to talk about the ICE updates that we've done within microbiology. I don't know if that was tabled on your agenda for today.
Yes, it was. Have you got time?
I have. If other people have, I can make it really brief. It'll literally be 5 minutes if people have 5 minutes, and I can give you a brief update.
Perfect. It's recording, so that will also go on our newsletter as well. Sorry, Vicky.
No, that's fine. Don't worry. Let me just share my screen. Right, hopefully you can see that.
We can do, yes.
Brilliant. Right. So let me just move slides. So I'm just going to miss some things out, but what I want to basically talk about is diagnostic stewardship in terms of pre-analytical. We switched to a new IT system within microbiology. We were the first ones out of the pathology divisions at Nottingham to switch last September. And following on from that, we've had conversations with GP colleagues in terms of some of the pre-analytical questions that come through, in that there's a lot of repetition, duplication, unnecessary steps and clicks within the ICE system. Now, pre-analytics is really important from our side because it allows us basically to get the right information to ensure the right tests are set up, the right bugs are investigated, and the right antibiotics are reported to you to help the patient. And this is a prerequisite for us and part of our guidelines that we have to follow, which are the UK SMIs and also our UCAS accreditation that we have to have for laboratories. So we do need to make sure that this is still a robust process. It's complex for ICE because we've got obviously yourselves and GP colleagues in the community. We've got community hospitals as well, and we have ICE users within NUH as well that use the system. So we have to try and make it fit for everybody. That doesn't mean to say that we can necessarily get one system that fits one group. We have to kind of find a middle ground to meet everyone. But I think we've made some good moves, and our aim is basically to improve the pre-analytical questions for some of the high volume requests that we get through. So I'll just take you through that. The startup page should look mostly the same, and in terms of microbiology, we have all our high throughput tests down here on the right hand side. You can also access all the microbiology tests via the microbiology tab as well, and all the serology tests will be in there also. If we take urines for an example, this is one of the ones which is highlighted to us that was causing a problem. If you select urine MCNS now, you'll see a prompt, first of all, to remind you that urine culture is not recommended for asymptomatic patients outside of certain scenarios, for example, antenatal and anyone undergoing urology procedures. You'll then come to first question. We've tried to simplify the system as much as possible. The most common sample type which comes through is an MSU, which is pre-selected for you to avoid clicks. If another sample is being sent, you click other, another box will come up, and you can obviously then detail what sample type that is, for example, if it's a catheter urine. You'll then be prompted in terms of asking if the patient is symptomatic or asymptomatic, and that information is important to us. If the patient is symptomatic, you'll then go on to a different set of questions. And what we've tried to do is provide a prompt here in terms of reminding people about dipstick testing in asymptomatic groups. Now, unfortunately, this sentence here is we're limited as to how many words and characters we can put into that, so we can't have big long sentences. But we've tried to provide as much information as possible to users to help them with prompts for questions. So this section has been improved greatly. Before, we had quite a few different clinical symptoms and scenarios that the user could click on in terms of detailing. Now we've simplified this to lower UTI, upper UTI, and other. Okay, and other could be something like epididymoarchitis. If that is the case and it's other, then we would ask you provide that information in the global clinical details field, which is at the end of the questions. Okay. And lower is pre-selected because that is the most common thing that patients present with. If it's asymptomatic screening, then we have two prompts. It should only really be antenatal and urology samples that are coming through to us, and that is there. And then we have a list of the antimicrobial therapy and antimicrobial allergies. Okay, again, we've tried to pre-select things to minimise clicks. So if the patient is not on antibiotics, that's the first one at the top of the list. And then we've ordered everything in terms of the most commonly used antibiotics for urinary tract infections. So they are all at the top, but obviously other ones are there further down in the list. Again, with antimicrobial allergies, no allergies pre-selected to minimise clicks. If your allergy is not listed, you would select other, and then we'd ask that you write that in the global clinical details field at the end for us to make sure we release the right antibiotics for the patient. We're not expecting you to duplicate all the questions in the global clinical details field, and I'd see this for any sample that you're requesting. It's just new information that you've not managed to capture, or information you think is pertinent and relevant for that test that you've not managed to capture in the questions that have been asked. If you have nothing else to add, just write not applicable. That is absolutely fine. Everything else will have captured the information for us. Other things which we commonly see are genital swab samples coming through. Again, we've got a prompt here in terms of saying this is not an STI screen, because the information you provide us for genital swab will dictate what samples, how we test the sample and how we interpret that. We have high vaginal swab, again pre-selected because that is the most common sample type which comes into the lab to help you. We've tried to order it again, so the most common things that we see coming from GPs are at the top, but obviously other sample types are there for you. We then would ask for common clinical details. Unfortunately, a maximum of 2 can be selected with the ICE system. It's a limitation that is there. If there are more that, again, you feel is pertinent, you can write that information in the global clinical details field. We're not expecting you to repeat anything if you've selected it from the drop-down list, just anything that's new. There's a question also of gonorrhea suspected. This is here to ensure that the right sample type is sent to us, because now high vaginal swabs are no longer considered an appropriate sample type for investigation of Neisseria gonorrhea, and it should be an endocervical swab. So that's a prompt there to remind the user. And then we have our list of antimicrobials and allergies as well. This is a universal list which is applied for all the kind of non-urine testing. And what we've tried to do is we've put the most common things at the top, the most common antibiotics that are used out in the community. But obviously it's a long list, and there is everything else in there. And you may see IV options, but of course that's because of the other settings that do use ICE as well. Okay, I won't do the rest because it's all very repetitive, and what I don't want to do, you've given a lot of time today as well, but you can see the common theme here is that if you have answered a question, there is no need to repeat that information in the global clinical details box at the end. Okay, that box is a prerequisite for all questions. If we remove it for one, we have to remove it for every single question within the system, so we have to retain it then. But yeah, anything that you haven't managed to answer, just put in the global clinical details box. And finally, I'd like to say thank you to our GP colleagues, Jonathan, James and Hussein, who have helped us in terms of helping restructure some of these. And Bhavin Mistry, who's one of our senior biomedical scientists in the department, who's leading on the IT side of things, and Steve Earley, who is our ICE expert, who's come in to help us with this. Thank you. If you've got any questions, you're more than welcome to email me. And I'd be happy to answer them for you.
Great stuff. Thank you very much. So there is a question. There's a couple of questions actually.
Oh, fabulous. If you've got time, happy to do it.
Yeah. Dr. Rachel Daly, does the MSU report show the pre-populated answers? I tend to repeat the clinical info on this so that the clinician reviewing the report is aware of all the info.
I'm not entirely sure. That's an excellent question from your side of things, because I don't get to see the ICE system. I'm not sure it is. But you will see, obviously, there'll be set fields. So you'll have symptomatic, lower UTI. So the question won't be there, but I think it would be evident, for example, for urines, what the question would have been from the answers.
Yeah, so Dr. Daly's also put in as well, sorry, as I write it all again in the clinical information box so it's visible when reviewing the report. And the second question from Dr. Margaret is, can you circulate all the slides so we can share with clinical teams, please? Would that be okay?
Absolutely, not a problem at all. So I'm sorry it's so rushed. I know I've been sort of squeezed in at the end. So
I'm so sorry. I should have really. So many names, so many people. But no, I think that was on me really. But no, thank you very much for coming in today. I think so. It's Vicky.
Vicky.Fleming.
Vicky.Fleming 1, isn't it, at NHS?
No, just Vicky.Fleming. There's only one of me, so excellent. I don't need a number. The main thing is we've tried to improve it for you guys, but like anything, it's always a cycle of improvements. So if you see things, ideas and suggestions, we're open for discussion in terms of microbiology and how we can make things easier and better for everybody. So
excellent. Thank you very much for your time today, and it's lovely to see you. And thanks for all your work on taking on board some of the comments from GP colleagues and to the team for making it happen, really. Thank you very much. Okay, that ends today's session, and we'll see you all in 2 weeks' time. Have a lovely week and a lovely bank holiday weekend, and see you all very soon. Thank you very much.